What is absolutely unique about this test is that it's gender specific. As you know, none of the tests, the diagnostic tests that are available to us today, are gender specific. They don't take into account the differences in symptoms. They don't take into account any of the differences between gender. This test does. So that's a very unique aspect of this test and a very important one. So what we did in the PREDICT trials, that we did a gender sub-analysis, basically comparing the two populations. What you can see here, just in terms of the demographics, is that there really are not that many differences in terms of age, hypertension, dyslipidemia between the two groups, the men and the female patients. What is interesting, however, is that there is a difference in terms of the symptoms. Once again, we're coming back to this notion that the symptoms are very different between the sexes. So clearly men had more typical angina and female patients had more atypical angina. And I think that, again, is very consistent with what's been seen. Very consistent with many other publications and findings is that the fact that female patients had significantly less obstructive coronary disease compared to the male patients. You can see only about 20% of the population had obstructive coronary disease in this group compared to close to 50% in the male patient population. Female patients had more minimal coronary disease. You can see up to 70% here compared to the men, about 40%. And this age-dependent probability of CAD. And if you go to the AHA website, this is a mirror image of what has been published on the AHA website in terms of the prevalence of CAD. So female patients, as we well know, have a very low prevalence of CAD in the younger age group. They hit menopause, and you can see this almost exponential increase in the prevalence of CAD, very different from the male population, where you have this steady incline in CAD over time. Okay, let me just break this down and make it simple for you. What we're looking at here is that we're looking at cases, which means that the patients have obstructive coronary disease, and compare it to the controls. And we're looking at the female patients and the male patients. Not surprising, when you're looking at the demographics, patients that have obstructive disease have more risk factors. They're older, both for men and women. They have more hypertension. They have more dyslipidemia if they have obstructive disease compared to controls. What is fascinating, and again comes back to these issues of symptoms, is that symptoms in male patients do predict obstructive coronary disease. So in male patients, they have those patients that have obstructive disease have more typical symptoms, atypical symptoms, and you can see this is significant. In the female patient population, though, there are absolutely no differences between cases, those with obstructive coronary disease versus no obstructive coronary disease, in terms of symptoms. So once again, we're saying that symptoms in female patients do not help in predicting the presence of obstructive coronary disease. Another way, and a more quantitative way of looking at this, is using that Diamond-Forrester classification to look at this. And essentially, once again, it shows the same thing. In the male patient population, when you take into account age and symptoms, it is predictive of obstructive coronary disease. You can see here by our ROC analysis, the C statistic is 0.66 in the male patients. In the female patient, it's 0.52. It's basically the toss of a coin. The symptoms really simply don't help risk stratifying patients for females. So what we then did was to look further into the positive and negative predictive value of the myocardial perfusion, or the non-invasive test, in this population. And I think, again, these are just fascinating results. So what we're seeing here is essentially this is the group of patients by gender with a positive MPI. And what you're seeing, and this is the percentage of patients that actually do have obstructive coronary disease by QCA. So what you're seeing is that you've got 41% of the male patients with a positive MPI, but only 20% of the female patients with an MPI, a positive MPI, that actually have obstructive coronary disease. So the positive predictive value, at least in this study, was very low, specifically in the female patients. We're only able to detect the disease in 20% of the female patients. Also, when you look at the false negatives, so these are patients with a negative MPI, but they do have obstructive disease. The false negatives are in the range of 25%. So you send your patient for a non-invasive test, it comes back negative. 25% of those patients actually do have obstructive coronary disease. So we do not have a perfect test. That's the bottom line. Now, breaking this down further and trying to dig into the issues of symptoms and once again trying to dissect it out by gender, these are patients, this grouping is the population with positive MPI, once again showing that in the male patients, if you've got typical and atypical symptoms, it increases your positive predictive value. So you've got 55, 65% of the population. If you have a positive MPI and typical or atypical symptoms, you will have coronary disease, obstructive CAD in that percentage of patients. You can see that in the female patients, though, once again, the symptoms don't help you, and the positive predictive value is low. So it ranges from 17% up to 30%. It's really not that great. On the other hand, we're looking now at the false negative patients. You can see that the false negative rates are in the range overall of 20 to 30%. And if you have typical symptoms, the false negatives, of course, go up. You expect that. 57% for men, 44% for female patients. This is not a great test.